Thank you, everyone, for joining us. My name is Jennifer Needle Suarez. I am a faculty member in the University of Minnesota Center for Bioethics. I'm really pleased to present our speakers to you today. We'll go through a little bit of housekeeping before we begin our talk. Next slide, please. Just a quick note for those of you joining from the University of Minnesota, our consult service is available 24/7 through Vocera. We'll use the Q&A function, so if you have any questions, please put them in there. I'll be monitoring that over the course of the hour. This will be recorded and available at the link you see, and we have closed captioning available, and an evaluation will pop up in the browser at the end of the event if you'd like to complete it that way. A presentation details document will be made available in the chat, and you can use that for your evaluation as well. And an email will be sent to you after this presentation. For those of you looking for credit, there will be a way to request it in the presentation's details document. For IPE students, you will participate in the post-group event discussion afterward. Biomedical engineering students, you will see the assignment in your course Canvas page, and you have to attend 75% of today's talk. So I'm very pleased to introduce to you today three colleagues of mine here at the University of Minnesota. We have Margy McCullough-Hicks, who is an assistant professor of neurology here at the University of Minnesota. We have Joel Wu, who is a clinical ethics assistant professor in the Center for Bioethics at the University of Minnesota, who also lectures in the Department of Health Policy and Management in the School of Public Health, and is my co-chair of the ethics committee here at the University of Minnesota Medical Center. And Dr. Benjamin Miller, who's an associate professor of neurology at the University of Minnesota and the director of the Neurocritical Care Division and medical director of the Neurocritical Care Unit. With no further ado, I would like to present Dr. McCullough-Hicks, Dr. Miller, and Joel Wu to talk today about brain death. And we will start off with Dr. McCullough-Hicks.
Okay, great. Hold on one second. Let me just share my slides. Does that look okay for everyone?
Yes.
Okay, great. Thank you so much, Dr. Needle Suarez, for that introduction, and thank you everyone for coming today. We have no conflicts of interest relevant to today's talk. So first, to go over the learning objectives. By the end of this talk, we want to make sure that our attendees can describe the social importance of the meaning and determination of death and the two current medical legal standards for the determination of death, either cardiopulmonary or death by neurologic criteria. Describe the procedures for the determination of death by neurologic criteria, and identify strategies to address common ethical issues that arise in the determination of death by neurologic criteria. Here's an outline for today's talk. I'll start with the introduction. So we'll begin by defining death, which really involves two key questions. First, what is human death? Is a conceptual or ontological debate whether death is the irreversible cessation of the organism's function, personhood, or moral status wherein they can no longer be harmed. This debate has spanned millennia and is not something we're going to be able to resolve today. But how we determine that death has occurred is an epistemological question addressing general standards for determining that death has occurred and clinical tests to show whether the standard has been met. Common standards include the traditional cardiopulmonary and whole brain criteria. So for our first poll of the audience, should patients and families be able to opt out of an established medical legal standard for the determination of death? Yes or no?
I always really enjoy these polls. I'm always really excited to see the answers.
All right, we still got a couple people answering. All right, so about 2/3 are no, and 1/3 is yes. That's a good place for us to jump off from. Here's a non-exhaustive list of reasons why a precise definition of death is important. And when people choose to opt out of an accepted definition, there can be serious implications for the resolution of all of these issues.
Right. And so based on that list, the non-exhaustive list, I hope we've shown you that death isn't just a biological process or a condition, and it really matters for society and community and the relationships we have with each other in society. And to be clear, what I mean is that beyond the biological, what death is really about in community is who has rights and who doesn't have those same rights anymore. And so whenever I talk or teach about rights, I always try to emphasize and remind everyone that rights really only exist in the context of communities or relationships, and that every right claimed or held by a person, like the right to medical treatment or the right to life-sustaining treatment, every right claimed or held by a person or a patient places correlated obligations on other people in community or other people that they're in a relationship with. The rights we owe to the living are not the same as what we owe to the dead. That's the distinction between the living and the dead. And this is, I think, the most well illustrated when we're talking about competing claims between different parties for the same considerations or the same interests or resources. So, for example, when a patient who may be dead by neurological criteria is competing with a living patient for the same scarce life-sustaining resources or treatments. The dead patient's claims and the dead patient's rights to those scarce life-sustaining treatments do not, and I would argue strongly, should not have the same weight as the living patient. The challenge is in knowing reliably, consistently, and clearly when a patient is dead and those rights are gone and the correlated obligations are also gone. And so that in determination should be reliable, consistent, and involves both medical criteria and thresholds that to some extent have to be chosen or constructed at the social and societal level. And so we'll address that more as we go on. But the point here is that death isn't just biological, it's social. And there are important social and ethical implications for how we determine death. And it's very, very important to be sure about the determination of death.
Joel. So, just a little bit of history on this. Before the 1950s, death was seen as a unitary event, determined at the bedside by checking for response to stimuli like and pupillary reflex, heartbeat, respiration, and carotid pulse. If all of these were absent, death was determined to have been declared. Traditionally, death meant the permanent cessation of respiration, circulation, and brain function. These vital processes were interdependent, and when one stopped, the other two invariably followed within minutes. But in the 1950s, there were medical advances like positive pressure ventilation and cardiopulmonary resuscitation that broke this interdependence. Circulation could be restored after cardiac arrest, and ventilators could sustain respiration despite complete brain failure. And this challenged the traditional societal definition of death. If brain function was irreversibly lost, but respiration and circulation continued with technological support, was the patient alive or dead? Then further medical progress, including organ transplantation from live to dead bodies, intensified the debate, prompting new questions about how death should be defined and determined.
So the questions that arose from these medical advances led to some serious practical, ethical, and legal concerns through the 50s and 60s. In 1968, in response to these concerns, Henry Beecher, an anesthesiologist at Harvard, convened the now famous Harvard Committee on essentially irreversible coma. Now, Dr. Beecher described the problem he was trying to resolve as the problem of the hopelessly unconscious patient whose brain is irreversibly damaged, and to address controversies about obtaining organs for transplant. This is really important because you both want to know what to do with a patient who is hopelessly unconscious or has an irreversible coma, and also when it's not ethically defensible to be able to procure an organ for transplant from a patient in that condition. Um, as Dr. McCullough-Hicks had previously, there was only one way of determining death before. The report introduced a new concept for the determination of death, which was irreversible coma, what we now know as death by neurological criteria. However, the report in and of itself did not have any legal force, right? So this had to eventually go through state legislatures, and states tried to address this independently, but unfortunately, all that did was result in variation across states. And variation is a huge problem because you don't want to have a situation where someone might be alive in one state but dead in another. In following the problem and the concern of the inconsistency, President Carter commissioned a report, and this commission eventually created a standard that became the Uniform Determination of Death Act. So we can go to the next couple slides. This is just a picture of the president's commission report on ethical problems in medicine and defining death. From this report, we can go to the next slide, came the Uniform Determination of Death Act. Now, what I really want to emphasize here is that this was adopted by all the states. This is the law of the land in the United States regarding the determination of death, and it creates two independent legal ways of determining when a person is dead and no longer has the same rights as the living. That's either irreversible cessation of circulatory and respiratory functions, or irreversible cessation of all functions of the entire brain, including the brainstem. Next slide. This is a picture of all the states that have adopted it in various forms. It's important to say that, highlight again that this is in every jurisdiction. And next slide, this is the law in Minnesota.
Thanks, Joel. Next, we'll move on to standard medical practice for determining death by neurologic criteria. First, how does death by neurologic criteria occur? In the vast majority of cases, catastrophic injury to the brain, such as hemorrhage or anoxic injury, leads to a massive increase in intracranial pressure that surpasses the patient's mean arterial blood pressure, leading to a drop in cerebral perfusion pressure, and finally, an absence of blood flow to the brain, resulting in brain tissue death. It's important to know and recognize that spinal structures are completely spared from these processes, and thus spinal reflexes may be preserved and observable in a patient who is dead by neurologic criteria. In the early 2000s, there was a survey of the top 50 US neurology institutions that revealed significant variability in determining death by neurologic criteria, including differences in timing, prerequisites, brainstem exam details, apnea testing, and acceptable ancillary tests. And so in response, the American Academy of Neurology did some investigation and also updated its 1995 guidelines, reinforcing adherence to evidence-based standards. The most important thing that came out of this was that they reported the critical finding that no peer-reviewed cases exist of patients recovering brain function after a properly conducted determination of death by neurologic criteria per the AAN guidelines, an observation that still remains true today. All reported cases of death by neurologic criteria mimics involved incomplete examinations. And so as a result, there's been a very significant movement to define a specific uniform standard for the determination of death by neurologic criteria. This is critically important to promote the highest quality patient-centered neurologic and end-of-life care, and by doing so to enhance our public trust. The ontological debate over the definition of death is centuries old and unlikely to reach universal agreement, but the epistemological question about how we determine death has clear legal, ethical, and medical standards. Consensus guidelines from the American Academy of Neurology, endorsed by all relevant US medical societies, must be followed meticulously to prevent errors or variability in diagnosing death by neurologic criteria. The evaluating clinician's primary duty is to the patient that they are evaluating, and they must be independent of any organ donation decisions to avoid conflicts of interest. The presumption going into a DNC evaluation is always that the patient is alive, and that's a point that should be explicitly communicated to families. The death by neurological criteria evaluation then seeks to disprove this presumption by confirming coma, brainstem areflexia, and apnea under appropriate conditions, ensuring accuracy and integrity in the definition. There are very important prerequisites that must be met before performing a death by neurologic criteria evaluation. First, we have to confirm catastrophic and permanent brain injury from a known cause that can lead to death by neurologic criteria, including neuroimaging to support this diagnosis of irreversible brain injury. Next, we have to rule out factors that can mimic death by neurologic criteria, such as hypothermia, hypotension, intoxication, neuromuscular blockade, or severe electrolyte imbalance. Patients must be observed for a sufficient period of time to determine severity and permanency of the brain injury and to exclude confounders. And if you don't have these prerequisites, you cannot proceed with testing. So who's doing the death by neurological criteria assessment? This varies by local law and institutional standards, but all clinicians need to be credentialed at their institution and adequately trained in the death by neurologic criteria exam. Adult patients require a minimum of 1 exam, but 2 are recommended, and children must have 2 exams that are at least 12 hours apart. There are ongoing efforts to standardize training in the death by neurologic criteria evaluation, and there are good online courses available to supplement in-person clinical training, including the Neurocritical Care Society's Brain Death Toolkit that's mentioned here, and I encourage everyone to look this up. Okay, on to the clinical process of determining death by neurologic criteria. There are 3 cardinal features. The first is coma, which is defined as no eye opening or eye movement to noxious stimulation producing only spinally mediated reflexes or no movement at all. Noxious stimulation has to be tested in all 4 extremities and the cranium, the face. And if you're unsure whether a movement is spinal or cerebral mediated, you can talk to someone who's more experienced than you. But if there's any question, an ancillary test is required. The second feature is the brainstem reflex assessment, which includes testing for blink to threat, pupillary light, oculocephalic, oculovestibular, corneal, cough, gag, and facial movement to noxious stimulus reflexes. And in infants less than 6 years old, sucking and rooting reflexes need to also be tested. Certain conditions like basal skull or orbital trauma or ruptured tympanic membranes prevent a full brainstem reflex assessment. And in these cases, an ancillary test is required. But all reliable clinical assessments need to be performed to confirm that the patient otherwise meets the standard for death by neurologic criteria in your clinical exam. The Brain Death Toolkit that I mentioned has very good videos on how to perform these assessments. We don't have time, unfortunately, to go through all of these. The third part of the exam is the apnea test, which evaluates critical functioning of the brainstem, specifically the drive to breathe when the chemoreceptors in the medulla, which is part of the brainstem, are stimulated by hypercarbia and then secondary acidosis. During this test, clinicians watch the patient for spontaneous respiratory effort, and any spontaneous respirations are a sign that brainstem function may be intact and it is not compatible with the death by neurologic criteria. We do apnea testing last in terms of the DNC evaluation so that the pretest probability that the patient is dead is high. And 1 test is required for adults, 2 for children. The process for apnea testing also requires meeting prerequisites of normotension, normothermia, euvolemia, eucapnia, and no hypoxia. You then pre-oxygenate the patient for 10 minutes and obtain a baseline ABG, then disconnect the patient from the vent and watch the chest and abdomen for respiratory movements for 10 minutes. If there's no spontaneous respirations, you get a second ABG, and if that second ABG shows an arterial PCO2 greater than 60 or 20 above their baseline in patients with known pulmonary conditions like COPD, the apnea test is consistent with death by neurologic criteria. If the test is inconclusive, but the patient was stable during testing, you can repeat it again for another 10 to 15 minutes, but making sure that you adequately pre-oxygenate the patient first. But if the patient was unstable, you have to get an ancillary test. During the apnea test, if the patient's systolic blood pressure drops below 90 or their oxygen saturation drops below 85%, you have to abort the test and an ancillary test is needed. Complications can occur from apnea testing. The most common ones are hypotension and hypoxia, which are really most likely to occur in the setting of inadequate confirmation of prerequisites prior to starting testing or inadequate pre-oxygenation. Tension pneumothorax and cardiac arrest have both been reported, but are exceedingly rare. On to ancillary testing. So death by neurologic criteria is a primarily clinical diagnosis. An ancillary tests are recommended only when components of the clinical exam can't be safely or fully interpreted, like I've mentioned in the past few slides. The reliability of ancillary tests in the setting of some confounders like hypothermia and high levels of sedating medication is unknown. And so you cannot get ancillary tests in these situations to determine death by neurologic criteria. Instead, you need to correct the confounders first. There are 3 accepted ancillary tests per the AAN guidelines: four vessel catheter angiography, SPECT cerebral blood flow studies, and transcranial Dopplers, which are only approved in adults. EEG, evoked potentials, and CT or MR angiography have been used by some institutions, but these are not validated and are not acceptable ancillary studies. In terms of documentation, the time of death is when the lab reports the ABG consistent with the PCO2 reaching its target value, or the time that an ancillary test is reported by an attending physician. Communicating the time of death to families can be really helpful in making it clear and finite in terms of determination of death. And physicians are required by both federal and Minnesota state law to contact an organ procurement organization following determination of death. To conclude the medical practices section, the AAN guidelines that I've mentioned repeatedly have really helpful detailed flow sheets and checklists to guide evaluations for suspected brain death and neurologic criteria. I recommend routine use of these resources, and they're really good if there's a question that you come up with that you haven't seen before. So moving on to ethical controversies and practical approaches, we'll do a poll question. Should families have a right to request second opinions or independent confirmations of the determination of death by neurologic criteria? About 2/3 of the way through. Okay. All right. So the vast majority say yes.
That's really interesting that 8% don't think that there may necessarily there may not need to be a right for independent confirmation. I take the view that you should be able to get an independent confirmation. The thing is, mistakes can happen, and they do happen extremely rarely, I want to emphasize, but as illustrated by this case, mistakes can happen, and errors are really, really bad. I would argue that the causes of these errors are an ethical problem in and of themselves, and that independent confirmations are an ethical and appropriate way to ensure that errors are not happening. I will want to emphasize again Dr. McCullough-Hicks's earlier point that the AAN is unaware of any cases where if you actually did and followed the guidelines correctly, that there has ever been an error if you follow the guidelines. Next slide, please. So errors are a kind of problem that do have ethical implications, but it's not the only issue, and I would actually suggest that it's a relatively straightforward problem. For the purposes of our conversation, I'd like to roughly divide the ethical controversies that we're going to talk about into several categories. So the first is problems in determination, which include the problem of errors and the problem of inconsistencies in practice. The second issue that we'll talk about is consents and refusals, by loved ones usually, or guardians, surrogate decision makers, um, that prevent an exam that is a part of the process for the determination of death by neurological criteria. And then finally, requests for what we're going to call continued somatic support, or what otherwise is the provision of life-sustaining or organ-sustaining treatment for a patient that has already been determined reliably to be dead by neurological criteria. Okay, next slide. Um, so briefly about errors. I don't want to spend a lot of time on errors because they're relatively straightforward. These should be remedied by appropriate standard of care practice. And so that's why we spent so much time with what Dr. McCullough-Hicks covered earlier. You have to do this the way that it's described in the guidelines. And if you do it the way that you describe it in the guidelines, you're going to avoid the errors. If you're not sure, get someone else to do it again. Okay. The next issue here is the problem of inconsistency. And so inconsistencies can exist across different settings. You can have inconsistency across legal jurisdictions, you can have inconsistencies between different institutions, and you can have variability and inconsistency between individual clinicians in the same institution. And that's a problem. Variations and deviations from standards is an ethics problem because whether or not someone is dead should not depend on or be a function of jurisdiction, locality, which hospital you go to, or even which doctor is there. So it's very, very important that there be consistency, and the consistency should flow from the standards that we set at the societal level down to the institutional and down to the individual clinician level. Clinicians and institutions should follow the laws. There should be policies, and clinicians should follow professional guidelines. This is really the solution to the problem of inconsistency. Next slide, and we can just bump to the next one. This is a piece from David Gurr in the Journal of Ethics for the AMA that just reinforces the point. I want to emphasize here when we're talking about inconsistency that this flows from the UDDA, which is the law of the land, which does state that there are two independent ways of the determination of death, right? And that both are not required. Each are independently valid. A quick aside on principal disagreements about what death is and the determination of death. Even with principal disagreements, I would argue that all members of society, and in particular all members of the medical enterprise and profession, should still abide by the common, consistent standards and procedures that are essentially required by the law and then informed by like the guidelines from the AAN. Because inconsistency and uncertainty would be incredibly destructive and would lead to a lot of harm and injustice. These deviations would really make it unclear when a person is dead and who's dead, where, and when. So again, the main point is that consistency is ethical, inconsistency is ethically problematic, and the deviations from law, policy, and practice in and of themselves, I would argue, are ethically problematic. So if you have a disagreement, if you have a principled opposing view, there are a couple solutions. The first is to resolve your disagreement and to litigate your position through the appropriate procedures and institutions. And that would either be at the governmental level with the law through the legislature, or if it's something clinical through the professional society. You cannot and you should not, I think, litigate it at the bedside. Ad hoc variation and deviation is a major problem. You have to go through the institutions and the norms and the procedures set by your society or the government. And if there does arise a bedside level conflict, I would argue that the best way to resolve it is actually through a process that addresses conscientious objections. Okay, next poll. Should patients and surrogates be able to opt out of or refuse to consent to the examinations required for the determination of death by neurological criteria? Should patients and surrogates be able to put a bar from clinicians being able to do the tests to be able to determine that someone is dead? Interesting. So strong majority says that people should not be able to opt out. So this is the next issue. We can go to the next slide. So we'll move on now to the question of whether consent is needed for testing, and is surrogate refusal something that can bar the determination of death by neurological criteria. This is increasingly one of the main concerns that has been arising in our society. Next slide. So the UDDA did not address this. They did not address the question of consent for brain death exams. It has come up in different states and in different settings. Some states stipulate that it is not required, and litigation outcomes have varied. What I will say is that we're going to rely a lot on the work of Thaddeus Pope, who I would say is probably the most reliable expert, probably the most influential authority on these issues, and is also conveniently one of our affiliate faculty and a member of our ethics committee. So what I want to emphasize here is that the UDDA did not address this. Death by neurological criteria is equivalent to cardiopulmonary criteria, right? And so when you determine someone death by cardiopulmonary or circulatory criteria, that holds up on its own and generally has never required consent for that evaluation. Why would it be any different for neurological criteria? The position that I think is the prevailing and correct position is that clinicians do not need to obtain consent unless otherwise stipulated by the institution's policy or a particular state law or regulation. It's worth emphasizing that this isn't the same problem of involuntary treatment that is a violation of respect for autonomy when you're providing treatment that is inconsistent with the patient's goals and values, right? We're not superseding or substituting our judgments about whether or not an intervention or a treatment is something that a patient should have, even though they may not necessarily want it or it doesn't align with their goals and values. This is about being able to reliably determine whether or not a person is dead. Okay, next slide. This is reflected in a position statement from the American Academy of Neurology, and they say that members have both the moral authority and the professional responsibility when lawful to perform the evaluation. Finally, emphasizing, but without the obligation to obtain informed consent. Okay, next slide. And what I want to emphasize here is some recent work by Thad, where he has done, I think, really convincing and recent research looking at all the cases and all the laws in many countries and comprehensively across the United States. And he has found overwhelmingly that courts say that you do not need consent. Okay. Just another paper of Thad's to emphasize the point.
Thanks. Yeah, in the same vein, questions have arisen about whether surrogates can refuse a death by neurologic criteria evaluation or just the apnea test. But as Joel mentioned in the AAN statement, which I really agree with, medical providers have the moral authority and the professional duty to perform a full evaluation, which by definition includes apnea testing. And this is really necessary to ensure diagnostic certainty and maintain public trust, just as we do when determining circulatory death. And that does not require consent and cannot be refused by surrogates. Concerns about apnea test complications do arise, such as the hemodynamic instability that I mentioned. But again, if guidelines are strictly followed, these are infrequent. And again, the test is performed last, ensuring a very high pretest probability that the patient being evaluated is dead. Lastly, all patients undergoing a death by neurologic evaluation, by definition with the prerequisites to start testing, have already suffered catastrophic, irreversible neurologic injury. And that's important to sort of think about in relation to any complications that could arise. But refusing a full evaluation risks misdiagnosis, which can have profound consequences for everyone involved. So open discussions need to be held with families before going about doing a death by neurologic criteria evaluation, families should be evaluated on the process, and they should be invited to observe, including the apnea test. And similar to what Joel was saying about consent not being needed to perform this, apnea testing still should be performed even if families request otherwise. Finally, let's move on to where some of the more interesting and ethically nuanced issues arise, which is continued for somatic support. And we'll go through sort of levels of accommodations that can be considered. We'll do a couple poll questions first. First, do patients and their families have a right to compel ongoing and indefinite somatic support after the determination of death by neurologic criteria?
Margy, can you say a little bit more of what we mean by somatic support?
Yeah, so somatic support is the term that we are using and that we like, that is sort of more colloquially known as life support or organ sustaining treatment. But really, we want to drive home here that the support being used is supporting the body and bodily sort of function, circulatory system and respiratory system after a patient is dead.
Right. Because you can't presume it's not sustaining life.
Yeah, it's not life-sustaining treatment.
And unless it's explicitly for the purposes of preserving organs, it's also not there for the organs either, because the body is probably in an active dying process, right?
Yeah. Okay, it looks like similar to the last question, about 80% believe that families do not have a right to compel. And then we've got a sort of similar question, but a little bit different. Is it ethical to require clinicians to indefinitely continue somatic support after determination of death by neurologic criteria? This one. All right. So vast majority say no.
Interesting.
Yeah. Okay. So just kind of going over continued somatic support. After declaration of death by neurologic criteria, somatic support is typically discontinued unless organ donation is planned or the decedent is pregnant and the decision is made to continue support for the fetus. While death by neurologic criteria is widely accepted as equivalent to cardiopulmonary death, some families request continued support until circulatory death occurs. And these requests affect not only the patient and family, but also healthcare teams and other critically ill patients who need ICU beds and significant resources, because providing somatic support for a patient who is dead by neurologic criteria requires significant time and critical care resources.
So there's been some interesting work done on this question, and there can be a range of reasons why the use and the occupation of these technologies to provide organ or somatic support will be provided. And there is a range of views by physicians on when it should be allowed or potentially even required. These are some of the reasons. But what I also want to emphasize here is that 48% of respondents said that they would continue to provide this somatic support and occupy the scarce resource due to fears of litigation. Next slide. And so we get situations like this. And I've taken a lot of this stuff, from Thad's work, because he just keeps up on all the cases. These are examples of situations where patients were determined to be dead by neurological criteria, but somatic support, the use of quote, life-sustaining treatment or organ-sustaining treatment, continued after death for this number of days. Is this a problem? Because we are accommodating something here. And is it something that should we accommodate? Should we not accommodate at all? Maybe a little, or what, right?
Yeah, so managing these requests for somatic support after death is really complex and controversial. As Joel alluded to, we think that respecting autonomy and religious freedom and privacy is extremely important. Yep. But continued support raises concerns about resource allocation, social justice, moral distress, professional integrity, and delaying family grief for the death of their loved one. So each case where somatic support is requested really requires a sensitive and empathetic approach to build trust between clinicians and the patient's family and understand the family's concerns. The goal here is to reconcile differences in a manner that's satisfactory to what the patient would want, the family, the medical team, and the institution, understanding that the patient is dead. Approaches to these requests fall into three categories: denying all of the requests, granting full accommodation to everything that the family asks for, or finding some sort of compromise in limited accommodations. So the no accommodation approach, which is immediately withdrawing somatic support against family wishes, is really generally discouraged unless critical resources are at stake and a living patient's care would be compromised in support of a dead one. So if there's a limitation in critical resources available. The next are requests for indefinite somatic support. So when the family requests indefinite accommodation, all authorized stakeholders in the welfare of the patient should be notified. And ideally, involvement of others with recognized mediating skills like clergy members, palliative care teams, or ethics consultants really should be considered at that point. I would argue should be required. But if a family voices objection to the declaration of death by neurologic criteria and is requesting indefinite support, while these discussions about accommodations occur, families need to be told that escalation of existing levels of care, including CPR, will not be provided.
So I would take the position that this kind of indefinite provision of somatic treatment and this indefinite accommodation is not ethically defensible. And I think it's been pretty well argued. I like this piece from Adam Omelianchuk and David Magnus. And they articulate essentially 5 reasons why indefinite accommodation is ethically problematic. The first is that there is no party to which a justifiable medical benefit accrues because the patient is dead. The second is that it undermines professional integrity of providers and that it is unfair to the wider community. The third is that it gives families a false hope for recovery and prolongs the grieving process. I do think that there's some merit to this, although it may sound, I think, a little paternalistic, and there is some room for debate about that. And the fourth, I think, which is really, really particularly important, is that it produces societal confusion by essentially permitting a negotiated and inconsistent standard of death that may vary from person to person. As a result, I think this pretty clearly makes the point that indefinite, potentially forever use of this kind of technology to keep a body functioning in a limited way is really not ethically defensible. This is consistent with professional society statements from the both, for example, the AAN and also the ACP. I think next slide has it. Right. So this is what the ASN. They agree that there are these harms. And further, you can probably go to the next slide. The AAN would go so far as to say that when there are disagreements about the withdrawal of what they call organ sustaining technology, what we call somatic support, over the objection, they actually argue that it would be ethically defensible to withdraw this kind of technology over the objection of loved ones, right? And that's to really get to the ethical point that indefinite support is ethically problematic, and the more ethical position to take is actually to be able to withdraw somatic support even over objection. Next slide. And the American College of Physicians Ethics Manual takes a similar position, although I think a less strict or harsh in the wording. They say, after a patient has been declared dead by brain death criteria, medical support should ordinarily be discontinued. One thing I want to emphasize here is that when we're talking about this isn't in the category of futile, non-beneficial, or potentially inappropriate treatment, as has been described in like the ATS, the Five Society statements. These are patients that have died, so they don't have the same rights. However, I do think that it's ethically relevant to think about the procedural commitments that we want to take, even though the patients are already dead, because I think it's more ethical to go through a fair and transparent process. Okay, next slide. So we don't want to offer indefinite accommodations, and we don't also want to abruptly just end things in a cruel and insensitive way. So how do we thread this needle? How do we simultaneously honor some of the interests of the family and loved ones while not committing ourselves to doing something ethically problematic where we just indefinitely support parts of a dying body? Okay, next slide. What I would argue is that there should be some reasonable and limited accommodation. Some people have called it different things, including finite accommodation. But why do we do this? Why are limited and reasonable accommodations important when the patient is dead and they don't have the same rights as the living? And this is really where I think the ethics and societal questions are, which is to say that even though no justifiable medical benefit accrues to the patient anymore, there are still interests of the living, of the loved ones. These issues matter because we're relational. We live in relationships and we live in communities, and the living loved ones can still suffer harms with how we intervene on the dead, even though they are dead. And I like to take a narrative ethics approach to this, which is to say that it can be it can be a tragic, and it can be a potentially unethical story when we do terrible things to the dead. It can be in the sense that we'll potentially take over or even hijack the story of a dead person in a way that forces the surviving loved ones to have to live with and remember a particular version of a story. And I do think that that is ethically relevant to take into account the relational and narrative interests of loved ones. It should carry some weight. We should take into account also faith commitments that should carry some weight, but it should not be absolute or controlling weight that supersedes the rest of the community's interests or the needs for consistency and the needs for certainty. Next slide. So practically, how do we balance these non-medical relational and narrative interests, these potential faith commitment-based interests with broader societal, professional, and community level interests and commitments? I think there's a few things that I really want to emphasize. The first is that there needs to be a set period of time. Ideally, this is specified in policy. Even better if it's in law. And the set period of time should be tied to, and it should be linked to a specific and achievable or objectively attainable near-term purpose or goal. This can be, for example, family arriving. This is the most common that's been referenced in the literature, and also rituals and faith commitments. I want to emphasize that these are not situations where there is a categorical denial or refusal to accept the idea of death by neurological criteria, because that's not an objectively attainable near-term goal, right? Okay, next slide. This is just from, I think, a really good paper about how to try to balance this. And what they mentioned here is that what they call finite goal accommodation is most frequently used to allow family members to arrive and say goodbye. Next slide. The same paper, I think, gives some really good advice. I think I want to keep on moving on because I want to get to our cases. We're running out of time. A few final points. We'll summarize and get to cases. The considerations that I think are particularly important to emphasize are that none of this is happening in a resource infinite environment, where this is not an ideal world where we have infinite resources. We're already really, really stretched. And so whenever we talk about accommodations, we have to also think about the competing interests of other people that are other living patients. And so accommodations that deny scarce resources to other patients and would result in avoidable harms or death would be, I would argue, unethical. And then the second is the unique case of pregnant patients and fetal interests. This is from the AN. In the event that a brain dead patient is pregnant, the ethical analysis should largely focus on the welfare of the fetus. We can get into that more in the Q&A later, maybe. So to briefly summarize where we're at, what rights or interests do loved ones have? And it really depends. There might be some good reasons to allow for temporary and limited accommodation, and that's about 24 hours, but it's not defensible when there's a competing scarcity that might injure another patient. Okay, next slide. And then what rights do the dead have? To just be very direct, the dead do not have rights. To the extent a determination of death is valid, all obligations to treat cease. And this is in our context of the medical enterprise. So there's no duty to treat or provide somatic support after death, except in New Jersey. And after death by neurologic criteria, treatment should stop. And as we addressed earlier, you do not need consent to stop because the dead are not patients. Okay.
I guess that leaves me, right, Margy? So, in an effort to kind of accommodate some of the Q&A too, we got a few cases here, and I've been trying to keep up. But these are just examples of some possible kind of sort of cases I may have seen. Anyway, so having a 19-year-old who coming in who basically had a drowning accident, equipment failure, unclear cause, anoxia for 60 minutes underwater. In Minnesota here, and specifically Minneapolis, we have ready access to ECPR, ECMO support after a cardiac arrest. So we were able to get them onto ECMO, and were allowed them to continue to function somatically speaking. He wasn't an organ donor, and the family had deferred, but they initially requested 2 days prior to am I the right microphone? To come in to see the family, but for the family to see him, but eventually it became more and more family to show up. And there was no policy, but really the problem here was the lacking of setting of expectations in our regard. You have to, this is a process, and the discussion doesn't happen at the end. And if you need to have you need to be talking at the, outset of what the entire process looks like for beginning to end, and setting expectations is really key. Next case. If anything to add, Joel or Margie, feel free to cut in. Apnea refusal. Now this is a hard one. Typically on the adult side, it's not very common. You see it more on the pediatric side, but having a patient come in who 28-year-old chromosome abnormality, congenital heart, previous multiple heart surgeries that they had come through, and after a prolonged resuscitative period, eventually edematous and herniated, resulting in death by neurologic criteria being met. But then with family, refusing an apnea test towards the end, another difficult conversation too, because at the end of the day, the exam was consistent with, and you can always offer ancillary testing if they wish, as another means if they don't wish to proceed with apneas, but that shouldn't be the rule of the land, considering guidelines dictate the necessary performance of an apnea examination.
Dr. Miller, can I interrupt you on that topic with a question?
Sure.
Just so we can get to some questions as we go. But a number of questions have arisen about the reality that the apnea test does carry with it a risk of harm.
Correct.
It's not high, but it's not zero.
Mm-hmm.
And does the fact that the apnea test carries a risk of harm change whether or not consent is necessary for that component?
Mm-hmm.
And I point to, there was, I think, 20% of respondents in the poll who believed that families had a right to refuse that because of the risk of harm. So I'm wondering if any of the speakers could address that piece of the question.
Well, This is what I kind of do a lot because the patients you're dealing with oftentimes are hemodynamically unstable, right? Because they're losing the ability to regulate their own blood pressure and they're on medication to maintain their blood pressure. And the risks associated with the apnea, as Dr. McCullough-Hicks said, of the changes in the patient's chemistry, right, starts to make these drugs ineffective. So that's why the guidelines do allow for ancillary testing if the dangers of apnea are there, or if there's, inconsistencies. It doesn't say you should skip it. It said that you should attempt it at least. And I know that, uh, it has its own risk, and I try to avoid it at all costs. I'd avoid risk, that is, um, because it's a known fact. It's low, but you're already increasing a level of difficulty in a situation that's exceedingly difficult, and you don't need to add that.
Right. What I think I would add here is that um, a few points. The first is that if we're going to do it, you should do it the right way because the guidelines try to minimize the harms. The second thing is that this is already on the background of profound injury, right? And then the third thing is that um, even though it potentially poses a certain kind of harm, the harm is actually a necessary condition to not just the determination of death, but also to have clarity about what interests the patient does or does not have. And so, in the absence of that, you actually don't know enough to be able to act ethically and I think in a professional or medically appropriate way until you get the information. So, there are competing and I think justifiable rationale and justifications for doing it as long as you minimize the harm of the process.
And if I can just circle, I think a lot of the questions really focused on what you addressed toward the end as far as accommodations. And there were a lot of questions about religious and cultural beliefs and different definitions of death. Obviously, we don't have time to go into those in depth, but I'm wondering if in a 30,000-foot view, you can address kind of how to reconcile these religious claims with the medical legal definition of brain death.
I think involving clergy or other sort of religious experts from the field in the conversations with the family, right? If the family has a pastor or a rabbi, inviting those individuals to be part of these discussions can be really helpful. Obviously, different religions' views on death and whether death by neurologic criteria is death are extremely nuanced, and it can be very helpful to have experts in that religion there for the discussion to make sure that the patient's families fully understand sort of what the religion's views actually are on death by and death by neurologic criteria. And a lot of times, their religious leaders can be helpful in coming to accept the diagnosis.
I think I would add one thing that I learned from Ben and Margy is that uh, it's really, really important, I think, both ethically and procedurally to involve everyone that's close to the patient early on. And that includes even to participate in the observation of the exams. Um, and then I think the thing that is probably less satisfying, but I think has to be said is that we do live in a pluralistic society. You have the option of potentially having a fragmented and fractured system where every different faith commitment has their own internally enclosed healthcare system. But I think that would be really catastrophic for a lot of other reasons. So instead, we do have one more comprehensive pluralistic society wherein I think we do have to operate um, based on these accepted and established standards and norms, recognizing that we should still, I think, do our best to try to accommodate without disrupting those standards and norms.
Thank you. There were a fair number of questions produced ahead of time asking about NRP, normo regional normothermic regional perfusion and DCD. We didn't get to those today because I want to share that Brendan Parent from New York University will be presenting on May 20th, and he will be talking about NRP. And I will also say that there were a lot of questions about distinguishing this topic in pediatrics. So perhaps that's something we, as a center, can think about for another Unpacking Bedside Bioethics, is focusing particularly on pediatrics. We'll stay a couple of minutes over because there were a lot of great questions and there are a lot of people that remain on this webinar at 1. But one question I wanted to direct toward you, Joel, was a question that came up about code status in patients that have been declared dead by neurologic criteria that are awaiting organ donation, and your thoughts about the ethics of performing CPR on a patient who has been declared dead, if their family is motivated for that person to become a donor.
I mean, that's really, really hard because it depends on what your, I think, intentions are regarding the intervention. Because resuscitation is not a benign process. I think this does relate some to the NRP question, but it's really, really important that if we're going to do the resuscitation, you have to do the resuscitation the right way. And you still have to essentially, I think, treat the patient as if they're patients and that they're alive. If they've already been determined to be dead by neurologic criteria, then the process for doing things that create better conditions for the preservation of the organ, I think they have to be done differently, and they have to be distinguished even though they may resemble the same intervention. I think it's ethically defensible, but you have to be clear about why you're doing it. Because if you're doing it to a dead person, it's different than if you're doing it to a living person. So is the question that the patient's already been determined dead by neurologic criteria?
Yes.
Yeah, if they're already dead by neurologic criteria, it's not resuscitation, right? It's essentially interventions that you're doing to optimize the viability of the organ for procurement.
Emergent
You
somatic
should do it
support.
in a way that it's the least harmful.
Yeah, and I think we can bring that up when Brendan Parent speaks about NRP, because some of those real issues are very similar in the NRP space. I recognize that there were a lot of incredible questions that we weren't able to answer here. And I hope that we will have an opportunity to respond to some of them, or that the speakers can. But I wanted to make sure that I just shared with the audience our upcoming webinars. Beyond Brendan Parent's, we have a talk on pediatric health disparities in April, and one on the importance of social determinants of health and clinical bioethicists. So I want to thank everyone for joining us today. The talk was very much appreciated by the audience. And we thank you for joining Unpacking today. And thank you to Dr. Miller, Dr. McCullough-Hicks, and to Mr. Wu. And we will see you all at our next Unpacking Bedside Bioethics.